Hello, my name is Peter Lawrence and as Senior Editor of the Journal of Vascular Surgery, Venous and Lymphatic Disorders, I'd like to tell you about the papers that we're highlighting in the November issue of our Journal of Venous and Lymphatic Disorders. The first paper, Prevention and Treatment of Dilator Injuries During Central Venous Catheter Placement, which is both our editor's choice and the CME paper of this issue, is by Collier from Sewickley, Pennsylvania. He reviewed 20 settled malpractice cases in which there was a central venous injury after placement of a central line. The mortality was extremely high at 85%, probably because these patients had an untoward outcome that led to a malpractice case. Injuries are most common in the left innominate vein, as seen in the diagram. Also, they often occurred when the sheath was advanced to the hub. There were significant recommendations by the author to avoid a catastrophic complication. First, always use ultrasound guidance. Second, when advancing the sheath, wire or catheter, resistance is often the first sign of a potential major vascular injury, so the wire sheath or catheter should not be forced. Next, if there is hypotension or cardiovascular instability, consider a major vascular injury in the chest. The catheter should not be immediately removed, since this may lead to uncontrollable hemorrhage into the chest. Lastly, have a covered stent available and use thoracoscopy to try to visualize the catheter in the chest cavity. If there is evidence of a venous injury, perform any procedure in an OR environment where the chest can be rapidly opened. The second paper, Impact of Inferior Vena Cava Ligation on Mortality in Trauma Patients, by Byerly and co-authors, retrospectively reviewed 443 patients with isolated vena cava injuries that were entered into the National Trauma Data Bank. They compared vena cava ligation with repair and found that those with ligation had a much higher need for fasciotomy and an increased frequency of deep vein thrombosis and acute kidney injury. Those with vena cava repair had a similar amputation compared with ligation and an insignificantly higher mortality and a comparable risk of compartment syndrome. Since the extent of vena cava injury and indications for repair varied by institution, the conclusion from this paper should be that vena cava repair is preferable, but ligation can be performed if repair is not technically feasible, or in the unstable patient for damage control. The next paper in this issue, IVIS versus venography for iliac vein stenting, is a single-center retrospective study of 155 patients who had both imaging techniques, and the authors compared the anatomy accuracy of each. They found that venography showed a significantly higher and inaccurate vena cava confluence than with IVIS, and venography often missed disease at what would have been the distal landing site. IVIS was more accurate in identifying the disease location. In fact, in 51% of patients, venography either failed to identify the stenosis or the location of the stenosis. The authors, based on their extensive experience with iliac vein stenting, recommend using IVIS routinely when stenting iliac veins, since it's the more accurate imaging device technique in guiding accurate stent placement. The last paper for this month, Significant Physician Practice Variability in the Utilization of Endovenous Thermal Ablation in the 2017 Medicare population from Johns Hopkins. They reviewed the Medicare data for endovenous thermal ablations and identified 102,145 patients in whom they underwent a procedure in that year. There was great variation in the number of ablations performed by a physician in a single setting, with a mean of 1.9 for 2,462 physicians. But there were 106 physician outliers, or 4.3%, who did a mean of greater than 3.4 ablations per patient. Those who were in this outlier group had fewer years in practice and had not trained in a vascular residency. This paper adds to the growing body of literature on an inappropriate venous care, which is also being addressed by the American Venous Forum Ethics Committee, who are in the process of developing appropriateness guidelines. We hope you enjoy these 4 papers and the rest of the November issue of the journal. And thanks very much for your attention.